Good morning. Good to see you all here. My name is Glyn Elwyn, as you heard, and I'm part of a group that studies shared decision-making and learning healthcare systems at TDI. And I'm delighted to be teaching as part of this master's course. Today we're following, I think, a theme. Thank you for coming up. This is Kevin and Lucas. I'll introduce them in a second. Today we're following a theme that I think we heard last night. I think it was a resident that came up saying she used to see 40 patients and with an electronic health record a few years ago and was managing. But now she feels she sees 10 and is struggling. And that's a story that's very familiar to me. I'm going to take you back to the early 90s. I was in Wales, in Cardiff, and I probably was one of the first practices that saw a computer arrive on my desk. And that first week of that computer was difficult. There I was trying to figure out a keyboard. Not just a keyboard, but trying to find a code that related to the diagnosis that I felt I was making. And then I was also writing notes, because we had to at the time both write notes and use this computer. And by the way, I had a patient in the room. And I was splitting my attention between 4 tasks, 3 which were very new, and 1 which was new to me because I was a new practitioner, seeing the patient. And I think since the 90s, that struggle of dealing with the technology in the room has just got worse. I hear stories of people trying to close their encounters way past 5 o'clock. So today, we're going to think about what can we do about this problem and many others that technology has brought to healthcare. We're talking about burnout as well, and I wonder sometimes if burnout is the right metaphor. It reminds me that a burnout is a candle blowing out or running out of fuel. It locates the problem in the person rather than in the system. And I wonder if the problem's in the system, not in the person. Anyway, it's my great delight this morning to welcome 3 people to talk to you about this. And we've structured it so that there's plenty of time for discussion. As you heard, the microphone is over here. And I hope you will join with us in a very active discussion about these issues. Lucas Ladden, graduate from 2015, I understand, of the master's here, is clinical systems optimization team at Optum Health. Previously from PricewaterhouseCoopers, installing EHRs into academic medical centers. So Lucas will be kicking us off. Kevin Larson, we heard from him as a faculty about 2 years ago. Roots in Minnesota in the medical school, but now Senior Vice President of Clinical Innovation at Optum Labs. But bringing experience from government, from health and social services, health and human services, and also from the Office of the Chief Technology Officer, and probably one of the architects of meaningful use. And then Shiv Rao, MD, a cardiologist from Pittsburgh now, who had the idea of trying to make use of a digital version of the conversations in healthcare. Could natural language processing of the digital record help clinicians be more efficient at using a computer? Not just the clinician, but also could it help patients remember what they had to do? So bringing technology and artificial intelligence to that digital record of the conversation itself. So I'm looking forward to what Shiv has to offer us. So it's my great pleasure then to ask Lucas to kick us off. Thank you, Lucas.
All right. Glenn, thank you for that introduction. Molly, thank you, and the whole MHCDS team, thank you for this. This has been a great couple days, and looking forward to the rest of the symposium. So real quick, as we mentioned, we're going to talk about some of the tools and trends we're seeing. I'll dive into some of the stuff we're doing at Optum Health, and more of the practical things that all of us can be doing. But what are the promising tools and trends we're seeing right now? So I think the biggest thing I've seen, especially coming out of COVID, is this is a huge priority. It's a real focus for organizations to do, right? We know we have internal data that talks about 2x, 3x in terms of inbox messages, right? In patient panels and things like that. There's an expectation on providers, and I'll say not just clinicians, but MAs, front office, back office, to do things faster with less people, and that's where technology can help. I like to focus on the simple things for now. There's a lot of really interesting things going on in the marketplace out there, right? I mean, AI has been in the news. For those that have Epic, you probably saw the announcement between them and Microsoft the other day. Huge promises, but what can we actually do now? And you'll hear me talk a little bit about that as we're moving forward. But it's very simple stuff that is relatively low cost if you think about in the realm of cost in technology and healthcare. So there are some innovative products coming out. I listed kind of 3 high-level things here. There's more coming to the market every day. I want to be cautious in how we think about them and how we put guardrails around using them, but there is some real promise moving forward. So ambient dictation and listening, Shiv will be talking about that. We use that a lot across Optum Health. Our providers have seen a huge reduction in time it takes to get a note and sign off their note and close out things. Improvements in clinical decision support tools. Kevin will talk somewhat about that. The amount of information and data we have in healthcare is crazy, right? And putting that together to help be able to solve things and make things quicker for providers, as well as improve patient outcomes, is really key for what we're trying to do over the next 5 to 10 years. And then we have all these AI-driven tools, right? That's been a lot of the stuff in the news the past month, past 2 months. There is some real promise here. We'll talk a little bit about how we're using that for some of our inbox messages inside Epic and other EMRs we have across Optum Health, but there's a ton of other opportunity with these AI tools as they start to learn healthcare, and we put guardrails around where they can find the data and what data they should be referencing as they're moving through things. So with that, Shiv, I'm going to turn it over to you, and I know you're on the line there somewhere.
Yeah. Hopefully everyone can hear me. It's a privilege to be here with you this morning. Really, really excited about this opportunity. Quick introduction in addition to what Glennon shared. I used to be a corporate investor for a large hospital system investing into technologies, and put a lot of investment actually into Carnegie Mellon University and started a machine learning and health program there. A lifetime ago, I went to Carnegie Mellon and in the middle became a cardiologist. And in my work these days, I've focused so much on AI. That said, when we think about like the broader landscape of interesting solutions out there, hopefully you can see my slides, but I'll just spend a couple minutes on this one because I think it's interesting before I transition into speaking a little bit in more depth about how we're approaching AI, at a bridge. But there's so many interesting aspects to tools that are popping up, and I think one of the aspects or the common denominators that I think we're seeing is that a lot of the technologies out there are finding ways to deal with the amount of information that is being generated in some way, shape, or form by the system. And so whether it's information in the medical record that is being summarized and being distilled and being structured, whether it's information from remote patient monitoring that is being summarized and distilled and being structured, whether it's actually really advanced analytics related to diagnostic support or clinical decision support. I think one of the really interesting aspects of where technology seems to be going right now is that it's finding a way to make more equal more actually be better in terms of the amounts of tools, the amounts of technologies that are a part of the healthcare delivery experience. I started seeing patients about 10 years ago, and I remember even at that point in time, I was just completely submerged in information. Even before going to see my patients the next day, I would do what we call a chart biopsy. I would open up the medical record and spend sometimes hours just reading up on my patients. I would look through their EKGs, look through their echocardiograms as a cardiologist. I would look through any number of recent notes over the last 6 months. And sometimes, over the years, that amount of data actually just increased in size. It went from not just the medical record to actually looking at a person's Apple Watch recordings. They would email them to me, or epic inbox messages that I needed to parse through in order to really better understand who this patient was the next day. I think over these coming months and years, we're going to see so many technologies that make that amount of information not actually burdensome, but actually, potentially a real boon for everyone involved in the healthcare delivery experience. So excited to be here and excited to talk in more detail about AI specifically over the course of this morning.
Thank you, Shiv. And Lucas will kick off the Optum presentation.
Let's see here. I can see it now. Oh, perfect. There we go. So 4 things Kevin and I are going to go over today real quick. Just kind of give you an overview of Optum Health and UHG in general. I think that's important just to set the context of kind of where we sit inside UHG and talk a little bit about the benefit we see from having the insurance piece as well as the care delivery piece. I'll talk about how we focus and develop tools and how we use the breadth of the physicians we have and some practical solutions people can deploy today if you haven't already done them, right? And we're going to focus on simple things that are very quick to do, relatively low cost, relatively low resource intensive, and probably more importantly, does not disrupt the caregivers with a ton of training and things that they have to relearn. And then Kevin's going to talk about what we're focusing on in the near term and future. We have some really cool things that we're piloting and have started to roll out across Optum Health that you'll hear about from him. So real quick here, I don't think it's any secret, United Health Group is a very large company. It splits into 2 main categories. If you think the United Healthcare side, right, that's our health benefits, our insurance side. And then the side that Kevin and I are on are our health services. Think care delivery organizations, physicians. Our businesses go into Optum Insight. That's kind of our consulting branch, if you will. Optum Health, which is where Kevin and I sit, so Optum Care and the care delivery organizations are within that, and that's where we'll be focusing. And then we have Optum Rx, those that know Heather Cianfranco, she leads our Optum Rx area, and she's a former, I think she was MHCDS 16, if I have that right. And our mission here is helping people live healthier lives and to make the health system work better for everyone, right? I won't go through all of this. There's a lot of facts here on our standard sheet, but we serve 130 plus million people across the country and across the world. That's a huge number. There's a lot of things we can gain insights from that on. Really important here, providers. You see the 70,000 employed and aligned providers. That's through contracting and stuff. We actually employ roughly 10,000 providers across the country. I'll talk a little more about that in a minute, but there's some real value there in what we can gain from the problems they're facing every day and connect folks across the country and in some cases across the world with our providers. This is just a map of kind of the care delivery organizations that we own across the country. So there's 25 plus now, but as you can see, we're pretty geographically dispersed. If we're thinking in the Northeast, I know a lot of you are from Boston, Reliant, Atrius, those are 2 of the care delivery organizations we work with a lot across the country. ProHealth Connecticut, Tri-State down in New Jersey and New York. Okay, so now let's get into kind of how we focus and what tools we deploy and develop. Because there's a million things out there. I think even at your own organization, you're probably inundated with different things that bring all sorts of promise to providers or to caregivers or to your front office staff. So how do we focus? First thing is site visits. If you're not in the clinics standing side by side with clinicians or MAs or anybody else, you're never going to understand what they're going through on a daily basis. Our team has clinicians, we have operations folks, and we have technical folks that go out into these sites. We embed with the caregivers as they're seeing patients just to understand their workflow and how good or bad that is, right? So there's very good things that happen that we learn and take somewhere else, right? And there's bad things that we have to come in and help them resolve hand in hand with them. We have what's called a clinical insights burnout dashboard. What this really is a fancy way of saying we have a ton of data to predict what providers might be more likely to burn out and leave, or providers that are doing something right that we can gain insights from. It's a really powerful tool we have that we can run at any time and kind of check in. I will tell you the most powerful thing we see, and if you guys have Epic, very easy for you to do, pajama time. If you see providers that are spending 2 hours post-clinic hours trying to close out notes. That's a problem that we should be trying to solve. That's probably one of the biggest ones we see, to be honest. Provider surveys, that's pretty self-explanatory. You can gain some stuff from that, but you know, that's more of a broad brushstroke in terms of what's happening year to year. Provider group and IT operational reviews. So we have new groups joining every day. Some are small, they're 2-3 physician practices. Some are large, 500 physician practices. There's a lot we can learn from them. I guarantee that they have things that they're doing better than we have ever done before. So we try and get into those sites and learn as much as we possibly can from them to deploy to our other providers, because there's very, very smart people out there that have had to figure out things throughout the years just to make their operation and daily work. And then data reviews, right? So we can dig into data all we want. Data's great, information's great, but it has to be actionable. One of the things we have is around our inbox message data, RX refills. I'll give you an example. We have teams of folks, 60 people at some care delivery organizations. All they do is RX refills. So there's some AI we're working on around that. And then where's the data going? Why is it going there? And is it getting to the right people? Sending data and sending spreadsheets and sending dashboards, if it's not getting to the right people that can make it actionable, you're kind of just wasting your time. So one thing I want to leave this group with is, if there's one action you can take today, get out, get in your clinics, if you haven't already, as leadership teams and as other caregivers or past caregivers. Get shoulder to shoulder with these people. We call it zero distance. You can call it whatever you want. Just to understand what they are going through on a daily basis and how you can help them solve that, right? Because help desk surveys sometimes does not bubble up to the surface, and really getting out there helps you understand. I know this is a lot of words, so I'm not going to go through it at all. You'll have these slides, but these are 3 practical solutions that you can deploy today. And I won't spend a ton of time on these, but what we tried to do here is think through, all right, what is in the marketplace today that can be deployed relatively quickly at a relatively low cost, and I say relatively because everything's expensive, right? And relatively low resources, not just from the clinical perspective, but also from your IT and your operational. So some of the things we work through here is password and logon elimination. I don't know about you, but we've gone to a 14-digit password. Can't repeat characters. I mean, it's crazy. The first thing I did when I figured out to not repeat characters was I wrote it down somewhere, right? I wrote it down in multiple places, to be honest with you. So we have tools. There's some in the marketplace called Imprivata Tap and Go or Imprivata One Sign. That's a popular one that you may have today or may not. Basically, you badge in with your ID card. Makes it super simple, relatively simple from an IT standpoint, and I will tell you from a per provider cost, it is very, very low to deploy something like this. That's not going to solve burnout. I want to be clear about that, but it's a piece of the puzzle that helps to put this all together for providers to help resolve some of the burnout issues we're facing. Inbox message reduction. So I think every person in here has inbox issues. I don't even have an EMR that I work in daily, but my Outlook, I get 500 emails a day. 90% of them mean nothing. We have some tools where we can go through and assess that. I will tell you, if you're an Epic customer, they have what's called Intelligent In-Basket. It's a free service that Epic does for you. If you have not done an Intelligent In-Basket assessment and you're an Epic customer, make sure you get one done. They can eliminate up to 25% of your messages, suppressing normal lab results, routing RX prescriptions for you, different things like that. And then online scheduling and patient self-service. This is a big one across our organization. As you know, we have call centers that do our scheduling and things like that. If you can activate your online scheduling, and I will say for certain appointment types, right? It doesn't work across the board for every appointment type. It doesn't work really well for net new patients, right? You want to have an established patient, but it's a starting point to eliminate some of that from your nurse call line or even patient messages that are coming into the provider. So anything you can do there for online scheduling or patient self-service is really important as we're moving forward. I'm going to leave you with this before I turn it over to Kevin. So go slow on this stuff. I think there's a lot of change fatigue, not just for clinicians, but for anybody that's delivering care or works in a care delivery organization. So we found The slower we go, even though people don't always want you to go slow, the better reception you're going to have to these changes and the better adoption you're going to have in the long run. Kevin, with that, I'll turn it over to you.
Great. Happy to be here. So Kevin Larson, I'm an internist and also a medical informaticist, but was initially the chief medical information officer at an academic teaching hospital, Hennepin County Medical Center in Minneapolis, which was a really early adopter of kind of broad-scale electronic health records. And as I just was starting early in my career to implement an electronic health record, who becomes my division director, but Mark Linzer, who's the national expert on physician burnout. So I got to actually deploy early EHRs under the watchful guise of the expert in medical burnout, which was a lot of fun. I want to highlight one thing that Lucas didn't mention, but I think is sort of key in underlying this. You manage what you measure, right? And so if you hear that you have burnout, that's one thing, but how do you know you're making an incremental improvement? So he highlighted how we're actually measuring burnout through surveys and measurement of things in the record. Additionally then, use your quality improvement best practices and focus on those activities. That's the other thing that he talked about doing. Something that I did at our health system was to hire what I called the medical director of documentation quality. We didn't really have a clinician involved in our documentation approach. And I put her in charge and I said, our job is to get perfect documentation. It's not to get too much and it's not to get too little. And we actually had a big ROI by improving our documentation at the same time cutting away about 30% of what the physicians were being asked to document. Because we were over-documenting beyond what the regulatory requirements were, beyond what anybody really needed, because no one was sort of focused on that as an activity. Let's see, next slide here. So here at Optum, you heard a number of these things. These are some of the things that we're doing. I'm going to focus a lot on the last one, that's investing in modern, scalable decision support to go across the organization. Something else that we've done here in the second one is a tool called Simple Note, which is a patient fills out their HPI, basically their symptoms, and then that gets automatically put into a documentation template. When they come to the provider, there's already a summary of what it is the patient cares about in a semi-structured way, and that has made that visit a lot better and faster for the clinician, plus a whole bunch of the documentation is already done. So we have a national program called Optimal Care, and this highlights what that looks like. How do we use our own analytics to drive what it is we think is important to focus on from both a tech and a practice change? And then how do we do things like contracting and incentive alignment to support that? This isn't just a tech play. This is how do you really use all of your business to think about this problem and be sure that you're staffed effectively, you're contracting the right people, you're really leveraging all of your staff in the best way. Here's that thing that I was mentioning, that Simple Note. So this is a symptom checker and a triage solution. It integrates with the medical record. It also saves a bunch of provider time. Again, we can talk about these in depth. We won't drain the slides, you'll get these. Here's what Lucas was mentioning about this automated inbox management. We actually had an inbox summit where we brought experts from a lot of our leading delivery organizations to say, what have you done? And we heard from them their best practices, and then we built a national program of those best practices so we could go with Lucas's team and others and technology teams, clinic to clinic to clinic, and say, okay, this is what we've learned, this is how we can help. How do we decrease the burnout and the volume of unnecessary, unuseful messaging? You can see, I think it's kind of interesting, again, you manage what you measure, and so you have to understand what's coming in by what type to know that you've actually made any change. This is what my team does, so this is what we call the medication recommender. So as Lucas mentioned, we have employed 10,000 physicians, but we contract with 70,000 in risk-based contracts. We want to deploy our best practice, our optimum way of doing care, but we have at least 10 different EHRs and probably 300 instances of those 10 different EHRs. So I can't just go to our Epic team and say, hey, change this in Epic and think it's going to go everywhere like Kaiser does. So we've built a tool using the interoperable standards that the federal government has mandated, CMS and ONC, so that tool can integrate into any EHR because they're mandated to have open APIs, they're mandated to have certain amounts of their data discrete and reusable. And so what we do is we use informatics best practices. I have a team of clinician informaticists, and they build these tools. We've taken, for example, the American Diabetes Association Diabetes Guideline, which is 200 pages long and has 900 different possible recommendations. And we have built that clinically and then built it in the technology so that when it pulls up in less than 2 seconds, it goes through all of that logic and says to the provider, for this particular patient today, with this past medical history and these lab tests, this is what the ADA recommends as the next best therapy. And so when we've done simulation studies with this, we're early in our deployment, so we're busy collecting the deployment. But with the simulation, the doctors were faster, and they were much more likely to prescribe according to the nationally recommended guidelines, because these get so complicated, they're hard to follow. And with that, I'll close. We're really happy to take questions.
Absolutely. We'll come to questions very shortly, but I think we'll hear from
Oh, yes.
Shiv first.
Shiv, thank you.
Yeah. So over to you, Shiv.
Okay, great. I'm going to share my screen, and hopefully you can see it again. Glenn kind of led things off with some, like a good kind of image of what like a clinical practice, what the care delivery experience looks like today. From my perspective, when I see patients, it's interesting that I'm sort of keeping in mind that I have 3 customers that I'm serving. I see a patient, and then I'm generating artifacts that need to serve other clinicians on the care team. And there's a lot of vanity involved in that. I want people to think I'm smart. I want them to see my assessment and plans and actually think that I've been very thoughtful in the way I've thought about my patient. And obviously, of course, first principle, it needs to help the patient in terms of coordinating that care and making sure the whole care team is on the same page. I'm also serving all things related to revenue cycle. I'm serving, entities related to risk management, risk adjustment. The way I document is going to make a big difference to the operations of the healthcare system. And then finally, arguably the most important consumer of all the artifacts that I generate is the patient. And they're going to get access to that note via the portal. Now, there's probably no other profession where you're generating notes with 3 audiences in mind. And that in and of itself creates such a cognitive overhead that it can be so difficult to sort of reconcile. And you end up being very, very split. And I think that's part of what leads to this sort of moral injury that Glenn was speaking to, is that there's just too much going on and you can't focus on the one person, the one entity you really wish you could just put all of your attention into, and that's the patient. So some years ago when I was at UPMC, we did a mapping exercise of trying to figure out what is the role of AI in being able to make healthcare paradoxically feel more human again. And a framework that we came up with was this, which is that AI has a way to assist, it could augment, and it could automate. I flew to a conference the other day, and I went on a plane knowing full well that plane had autopilot capabilities, that they were going to leverage those capabilities at certain parts of the flight more than others. But I certainly wouldn't have gotten on a plane without a pilot. I don't have that kind of trust at this point in time. And so in some ways, these technologies, especially around AI, can be so assistive. They can really, force multiply the clinician. In terms of force multiplying healthcare professionals, it can also augment. I think about population health. I think about how so often we're looking at analytics at a really high level. We talked about making sure that we measure what we want to really manage. And when you've got this data really across a swath of people, and you can then decipher patterns, you can start to make a huge difference in terms of not the air traffic controllers, but the other sorts of controllers that are on the payer and the provider side of healthcare. But then finally, there's automation. And I think we have to be sort of very mindful about how we apply automation or automative sort of analogies or metaphors into healthcare. This is one way to think about that. So on the x-axis, we have this idea of consequences. On the right side, there's a high consequence for an issue, a factual inaccuracy, for example, in the case of AI. On the y-axis, we have volume of decisions, how much is actually happening. So where there is a low consequence for a factual inaccuracy, where there is a high volume of decisions, or any volume of decisions, regardless, there's the possibility for automation. And so when you think about those potential use cases and you're mapping that across not just the care delivery experience, but also maybe across other workflows that are happening inside the clinic, it turns out that back office workflows around billing and coding, that there's just a little bit more, there's more possibility there to actually try to not just assist and augment, but potentially even automate, just totally reinvent that workflow. Now, in the top right quadrant, we have a high volume of decisions, but we also have high consequences for inaccuracy. And when I think about those use cases, I think about, for example, clinical decision support, for example. I see patients in a clinic, and I see a certain type of patient pretty frequently. And it may seem as if this patient is following a very archetypal sort of pattern, for example, for heart failure. But the truth is that there's so many different dimensions to that patient that we're not even capturing from a digital perspective, that being able to simply assist me is actually more valuable and probably more realistic than being able to automate my decision from a clinical perspective. So the metaphor that I think is emerging now more than ever before in light of what's happening with generative AI is a co-pilot. It's not necessarily automation, but it's or an autopilot, but it's a co-pilot that can kind of be a part of those conversations or be a part of those workflows and assist the clinician, augment the clinician to help them be the best version of themselves. Now, I can kind of speak a little bit to one space that we've already nodded to that certainly has a lot of activity going on and where Bridge spends a lot of its time. It's in the conversation. It's in relation to a lot of the clerical work that's downstream of the conversation that includes documentation. So when a bridge is a part of the workflow, what the technology does in real time is it doesn't just sort of transcribe, but it also summarizes the conversation. And there's so much opportunity around summarization for sure. Doctors, nurses, care managers, therapists, we all need to document. If you really believe that healthcare is about people, then you have to believe that healthcare is about conversations, that upstream of all the diagnostics, therapeutics, experiences, outcomes, risk adjustment, coding, and everything else, the costs in healthcare, upstream of everything, there's usually a conversation between a professional and a patient, and they're happening virtually, in person, over the phone. And being able to be a part of those conversations or inject technology into those conversations to not just summarize, but also structure information can unlock so much value downstream. We just talked about a use case around potentially being able to pull the history of present illness even in advance of the actual conversation that happens in the clinic. And then being able to serve that up in a semi-structured way. And that's a great example of ways to think outside the box about these care delivery workflows and create so much value, not just with sort of summarization technology, but also with structured data. Now, the way a bridge works is when I see a patient, I just sort of, turn it on and the technology will take it from there. But just to sort of illustrate where we are with generative AI, I can do a very quick demo. And Glenn, I'm wondering, is there someone there who'd be willing to play guinea pig patient with me?
I'm not sure. Kevin, do you want to have a go? Sure. Kevin's going to go have a go with you.
Okay. I hope that your microphone is on.
It is. Can you hear me?
Yeah, perfect. Okay, great. So Kevin, if you were my patient in clinic, this is the phone app that I use for in-person. We also have an API for virtual and for telemedicine. And I just walk from room to room to room. And the first question I might ask you is, hey, Kevin, do you mind if I use this note-taking solution? And it's probably a very similar workflow as the technologies you're experimenting with, you're building and co-developing as well. And then, I live in Pittsburgh, so the first 10 minutes might be about the Pittsburgh Steelers or the snow outside or some restaurant I went to recently, and that's okay. The technology's job is to find the signal wherever it's buried, pull it out, summarize it, and structure it, and then slot it right into the medical records discrete fields. So why don't we just sort of freestyle a conversation? I'm going to press record and we can start talking. Hey, Kevin, I heard you're having some shortness of breath. What's going on?
It started about a month ago, and whenever I walk up the stairs, I get winded by the time I get to the top.
Okay, interesting. And do you find that it's getting worse over time?
It seems to be. It's really hard to tell. I think at first I didn't really notice, but this last week was really rough.
All right. Are you having any kind of chest pain or chest pressure?
I haven't noticed any chest pain, but boy, I have to sit down and rest for like 5 minutes whenever I go up my stairs.
Okay. Are you having any lightheadedness?
Not that I can remember.
Okay. Have you noticed any swelling in your ankles recently?
Now that you mention it, I think I have seen a little bit of swelling, especially at the end of the day before I go to bed.
Okay, interesting. So I'm looking at my medical record right now, and you have a history of diabetes and hypertension, and you know what? Your last hemoglobin A1C from January was 1 billion, so that's really high. Your body is fully glycosylated. So are you taking your metformin every day?
It was so hard to get it. I lost my insurance, and I stopped taking my metformin.
Okay. So I really want you to take metformin, 500 milligrams twice a day. I'm going to ask our social worker to figure out a way to get you this medication. They're going to call you on Friday and give you some next steps to be able to fill it. Okay?
Great, thank you.
Okay. Now, in terms of your shortness of breath, I'm worried this could be related to your heart. Your great-grandfather had a history of coronary artery disease, and you also have these other risk factors. So I think we should take this seriously. I want you to come in this afternoon. Let's get an EKG and an echocardiogram. That's going to give us a sense of how your heart's functioning.
Okay, what time?
Okay. Why don't you come in at 4 o'clock?
Perfect.
All right. And then remind me, do you have any medication allergies?
Sulfa.
Okay, because in terms of your hypertension, your blood pressures have been in the 180s over 80s range. That's way too high. And I'm sorry to confront you on this. I saw you at McDonald's last weekend, and you had 6 Big Macs in front of you. So I'm going to ask our nutritionist to call you next week and start you on a vegan diet, a low-salt vegan diet. It's going to be miserable. And then I also want you to start taking metoprolol, 25 milligrams twice a day. I think that's going to be good for your blood pressure. It's also going to be good for your heart in general. Okay?
Okay.
All right. Last thing, you mentioned some swelling in your ankles at the end of the day. I think that's probably related to your veins and not related to your heart, but we'll definitely keep an eye on that. But otherwise, I think we have a good plan. Now, one last thing, you're under a lot of stress at work. Are you still drinking 5 bottles of wine every night?
I've cut down to 4.
Okay. So I'm going to ask our behavioral health therapist to call you next week and give you some strategies to taper down on your alcohol. But otherwise, I think we have a good plan. Okay.
Thank you.
All right. So sometimes we make these demos very silly because I think it kind of exposes or demonstrates the power of generative AI and AI in general. So when I started investing into technologies on behalf of a large health system some years ago, I remember putting a lot of attention into NLP. And one of the reasons is that most of healthcare is unstructured at this point, for better or worse. A lot of healthcare is about a conversation, and conversations end up being documented as stories. We even call our archetypal note a history and physical. And so being able to leverage technology like natural language processing to structure data from unstructured information can be so powerful. Now, I'd say even 5 or 6 years ago, NLP looked very different than it does now. In late 2017, there was a paper published called Attention is All You Need in the AI world. And that was the first paper about a new type of machine learning model called a transformer. And that technology is now taking the world by storm because the T in GPT stands for transformer, but also the type of technology that underpins a lot of the quote unquote new foundation models that are really reinventing how we think about generative audio, video, and all the other kind of technologies out there. They're all really underpinned by transformer-based technologies. So I'd say any NLP systems that were built arguably before 2018 are probably trying to find a way to completely reinvent their stack. But if you've come since then you've probably, if you're an AI native company or research group, you've probably figured out a way to leverage them as power tools. Because if you leverage them as the be all end all, you get a whole new slew of challenges. And a lot of us, I think, are going to become more and more attuned to this word called a hallucination, where the technology can make stuff up based on what it's seen. So here's an example of a note, and hopefully there aren't too many hallucinations in here. But the way my workflow goes when I see 3 or 4 patients every month is I see my patient, I hit stop, I've got my note within seconds. If I like it, or actually regardless, it just flows right into the medical record. Let me show that note to you on the desktop because we'll be able to spread out just a little bit more and really look at the power of what this technology can do anymore. So hopefully you can see this screen. Now, let me orient you first. So we're seeing a note on the left, and we've sort of sequenced the sections for the purposes of a demo, but here's the history of present illness. Patient reports experiencing shortness of breath for about a month, particularly when walking upstairs, and it seems to be getting worse. They've not noticed any chest pain or lightheadedness. They have observed some swelling in their ankles, especially at the end of the day. They have a history of diabetes. They stopped taking their metformin due to losing insurance. Patient has a sulfa allergy and a family history of coronary artery disease. They've been under stress at work and have cut down on alcohol. I don't know about that last line. You went from 5 bottles to 4 bottles, but we'll let that go. Here's the next steps, and you can see this is a problem-based assessment and plan. We got shortness of breath, and by the way, every single one of these diagnoses is mapped to an ICD code, which with the right demographic information, we actually even map to HCC codes. And so that's that second customer of my note I was speaking to that we want to be able to kind of serve. And it sort of summarized that story with all the kind of criteria that you would need for the optimal document, but it's also put in the plan, EKG and echocardiogram this afternoon. We'll also start the patient. It's put in metoprolol and it's put in the metformin too. So it's confused that metformin should be in the high hemoglobin A1C section. And then the social worker, the swelling in the ankles, the high hemoglobin A1C, the alcohol use. And so if we go down further, you can see family history. Great-grandfather has a history of coronary disease. You're drinking 5 bottles. That should be down to 4. Allergic to sulfa. If I wanted to trust and sort of verify any part of this note, if I hit, say, not venous insufficiency, but let's say chest pressure, I can very quickly go to the ground truth. And once I'm there, I can listen to it. Are you having any kind of chest pain or chest pressure? I haven't noticed. So the idea is that in this new world, every single AI-generated summary should map to the ground truth. And when it maps to the ground truth, you can very quickly trust and verify. Because in this new world, in this new paradigm that we're all going to be in over these next months and really into the future, trust is the new network effect. Trust is the thing that is going to really differentiate any of these new solutions from others. And trust is probably some combination of transparency, the ability to do that sort of mapping, it's credibility, the ability to really demonstrate and write papers, for example, and reliability. So I'll stop there, and I'm excited for this discussion.
Thank you, Shiv, and thank you, Kevin. We're worried a little bit about you, actually. That was a really good overview of what you're doing at Optum, and some very practical work. But I also think we saw an insight into technology as a co-pilot there. I'm just wondering whether people have got questions immediately. If you do, come up to the mic here and ask questions of any of these 3 people. But I'm going to kick off by asking you to think about some other aspect of technology, which is to prepare the patient before the visit. You've mentioned dashboards and patient-reported outcome measures. Jean Nelson, one of my colleagues at Dartmouth, has this wonderful idea of preparing the patient for what they want to talk about, but also what treatment possibilities they might have in the future. Are you thinking about visit preparation as well?
Certainly. I think it's more than preparation. I think it's how do you. So I grew up, my brother's a type 1 diabetic, and what I noticed over the course of my life is the locus of control changed from the doctor and the doctor's office controlling everything to a lot of self-control with the right tools. So an example of that I love is called the Swedish Rheumatology Register. And what this does is gives patients a set of parameters. Here's how much pain medicine you can take. Here's how much steroids you can take at home. And by the way, track your symptoms. And then you come into the doctor after you've been self-managing, and they have your data plus the data of all the other people in Sweden that also have your same condition. And you look together and you say, okay, this is what we now do next time. I think too often we think about how do we optimize the visit, not how do we give control and support to the patient.
If it's all right, I'll even take a simpler
Yep.
kind of aspect of that of the patient and getting them ready for the visit. So e-check-in, right? So and that reach out, that's usually done by a nurse or something before the visit. There's technology out there today. Your EMR likely has it. We have some homegrown stuff that if that patient is engaged digitally, they can get checked in, they can update their symptoms, they can verify their medication. All of that saves time prior to the visit. So you don't, yes, you still have to trust but verify, but it helps speed up that visit so you can start interacting with that patient much sooner about why they're there for that acute or longevity visit.
And I'm just going to turn to Shiv very quickly now. Do you also provide information from this digital record to the patient, maybe to prepare for the next visit? Is that a feature as well?
Yeah, absolutely. So I wasn't able to kind of share my screen on this, but the clinician, after they've trusted and verified, they've organized that note. As you said, it's a co-pilot. It's not automating necessarily. There's always needs to be that clinician expert who's in the loop. But once they do that, hopefully it takes split seconds. We're hearing that we're saving people up to 2 hours a day. But once they hit send, then their patient can actually get a summary of that. It can be in the portal, but what the summary looks like for patients in our case, it takes the note and it distills it at a 4th grade reading level with inline definitions of all the medical jargon. And then we have an app actually, and we can do this via text message or phone call as well, that will nudge them in a week or 2 weeks to actually, remind them to go from 5 bottles of wine to 0 bottles of wine or whatever the case may have been. So I think the idea of using technology to be an extension of the best nurse or best doctor's best intention of being there for their patient, even when they're not in front of them, is where I think I'm so excited for technology to go. I think about programs for Medicare like Health Quality Partners that maybe have a challenge scaling, because how many people can we send to people, how many care managers can we send to a person's home to go through the discharge instructions? So if technology can start to do that in novel ways, it could be really a game changer.
Okay, we have a question here, please.
Hi, Patrick Burke here with the class 2014. So I appreciate the pragmatic nature of the discussion about particular tools and what they have that. So with the spirit of that, to go over the more cruder aspects of this about cost. And so, for example, if we're looking at, say, the Optum Solutions, and Optum is a company that sells products, and so if one says, oh, simple note, interesting, does Optum then from that point say, okay, well, then you'd have to buy into the Optum practice in order to use these tools, or are these particular solutions being sold bit by bit, as well as then for the Adrift tool, I got that right, is what's the typical cost for admitted large size organizations, et cetera, et cetera. And I suppose the only minor follow-up question to that, especially for resource-constrained and more conservative organizations, to not necessarily buy the shiny new thing, but see, okay, is this time and tested? Is there any thoughts about, oh, gee, let's get that next week, versus, gee, maybe we should wait, and different thoughts on that. So I appreciate that.
So I can start. So my team is focused right now on building for internal use, but we're partnering with our consulting group about what the commercial offerings will be. Our own practices are like yours. They can't take everything, even if it's given for free. They want us to prove that not only does it save time, that they make money, they have a positive ROI in the investment. So we're busy doing that, hopefully showing that the better adherence to the right medication regimens decreases downstream utilization. And we have a lot of reason to believe that that's true. And so these will be sold as a way for you to actually have profitability, not just as a way for you to decrease a burden.
And Patrick, I'll talk the Simple Note example that you mentioned. So yes, we sell that externally. We haven't yet, but we can. We have patents on that. And you don't have to be part of Optum to do that. I know there's a counterpart team to mine. I kind of do the internal installs of Simple Note, and they do the externals, and they're talking with various organizations around the country to deploy that.
Shiv, do you want to respond to the question?
Yeah, absolutely. Cost is obviously absolutely a part of the equation. I think what's going to separate a lot of entities out there in the coming years is like who can actually take risk, who's willing to really put their money where their mouth is. And just from a cost perspective too, I think where technology will take the world is that we'll be able to democratize a lot of this value in a way we haven't before. For example, we've talked about this metaphor around a co-pilot, and in the past, I think co-pilots have probably invoked in some level a service, maybe a tech-enabled service, but still a service that has constraints in terms of how much you can scale this across all of your staff who are burning out, who might need help. And I think with technology like generative AI, I think we're going to see very quickly this become sort of just a part of people's workflows, like good air conditioning. It's in the background, you don't notice it. But it's also going to be democratizable because the cost structure is fundamentally different than anything that's service centered.
I wonder if there's going to be an ROI equation about these kind of technologies that comes to the fore. I haven't seen it yet, but it's probably coming. Please.
Good morning, Peter Kachapa's class of MHCDS class of 13. Really a great presentation. I could listen to you guys for like 3 days, and I loved seeing the natural language processing. But there's a little quote you had, or a little imploring you had at the bottom is for the C-suite to come out and actually see what practicing doctors are doing. And I have a quote in my office, it was up there for many years. It's from Upton Sinclair, author of The Jungle, who said, "It is difficult to get a man to understand something when his salary depends on his not understanding it." And I have that there because even as medical staff president of a 500 physician hospital, I could not get people from the C-suite to come down and sit with me while I was practicing internal medicine, seeing how he's being tortured. We didn't have a chief medical information officer on, and they did not turn off the med alerts. So every single medical interaction, drug interaction, was popping up. And Radcliffe has done studies on alert fatigue, and I mean, my voice is quivering because it's bringing back I'm getting PTSD from thinking about this era. And so seeing this demonstration was really great, because 30 years ago when I first started thinking about it, there were two issues with EMRs. One is, how does it get from the doctor's brain into the computer? And secondly, how does that all get organized? And I see, this is the first light at the end of the tunnel. And I just have one other comment. How many of you know who Judith Faulkner is? Judith Faulkner started Epic Systems. Judith Faulkner, Epic is a privately held company. She owns 47% of it. And she was quoted sometime in the last 2 or 3 years as saying, basically, and I could quote it, but I would summarize, she does not believe that that EMR, EHR, has contributed to physician burnout. So that's why you've been tortured for the last 15 years. And I would say it's not Epic that's going to solve it. It's going to be guys like you. It's going to be the C-suite investing in these natural language processing systems. And sorry if I've gone on too long, but
Do you want to respond?
So I'll respond with one of my, so I was the medical director of Meaningful You Said, to go around the country convincing doctors why they should get EHRs, and felt like I had a giant target on my back. But one of the articles I went back to over and over again, it's I think from like 2012 in the New England Journal, it's called the IT Productivity Paradox. And it's actually a study of banking in the 70s. And when banks automated, they found 10 years later only half of them were more efficient. And the half that were more efficient had actually changed how they did work. They had gone in with intentional process redesign on top of their new technology. The half that were still at the same productivity level just tried to do everything the way they always did it, now with tech. So I'm a huge believer, you actually have to redesign your practice, you have to redesign your business around the new opportunities of tech. You can't just layer it in and do everything the same way.
So Shiv, you're still
Yeah.
there.
Yeah.
One of the things I realized when I saw some of your technology was to say, would this actually turn the tables that the patient holds the record? But that's a very different discussion. But
Yeah.
there is a possibility of transforming the ownership of the record here.
Yeah, absolutely. And you know, I have a quick thought too on the prior kind of question. You know, I have a slightly different point of view. I think that the medical record really is a reflection of the paradigm that we operate in as clinicians, like just healthcare. I used to be on a clinical documentation improvement team in the hospital. We would go from clinic to clinic to clinic. We would do pizza lunch and learns. We would try to convince clinicians across different specialties to write their assessment plans in a certain way because it would lead to so many efficiencies from a revenue cycle, from a coding, from a risk adjustment perspective. All the clinicians sat there with 1,000-yard stares. They could not take it. You know, all they wanted to do was get back to seeing their patients. They didn't want to be told how to actually write a note. A note feels so beneath, you know, you know, what they're really, why they went to med school, why they went to nursing school. And at the same time, we had to do it. And so much, I think, in healthcare, including the systems that we've built, just reflect the incentive structure, the requirements that we put on people. And so I don't know that any single medical record hasn't been rational in terms of what it's designed, or that they've had necessarily bad intentions in terms of what they've designed. But we have a very upstream issue in healthcare that certainly technologies like AI will be able to tackle, but the best way for us to actually tackle those problems is probably certainly beyond my current pay grade, but it's something that people in the room, you know, in this classroom could probably tackle. Yeah. And I think if we can start to get at that, we can start to really make a huge difference. For example, even in the last couple years, I started to shed, you know, aspects of my documentation that thankfully were always useless, like review of systems. It's now not pertinent to the way billing actually happens, so I don't do it anymore. But it's that sort of change, little by little by little, that will change how these medical records are designed, because at the end of the day, they are designed to help us keep the lights on inside clinics and hospitals.
I have just one more little quick comment. Before I went to medical school in 1982, I worked for Digital Equipment Corp, doing human factors engineering, software psychology, and the basic premise of most systems is you want to make them easy to learn and easy to use. And as soon as I saw Epic, I'm like, oh wow, this violates so many rules here. Thanks for all your comments. Appreciate it.
Thank you. Can I just take a time check? I'm without my watch. What time is it?
9:15.
9:15. So that's when we're supposed to stop. But I know we've got another question here. Can we overrun a little bit? Okay, thank you very much. Please.
Hi, Karen Adelson. I'm the Chief Quality and Value Officer at MD Anderson Cancer Center and a practicing oncologist. Shiv, I got to tell you, I'm sold. I'm not speaking for my organization, but this is probably the first technology I have looked at in years and said, this would really make a difference. So my question for you is, where is Abridge? How well is it integrated into most EHRs, the big ones like Epic? Do all of those elements of plan directly tie to orders that are teed up for the doctor, making life much easier? And sort of, you know, how fast and how ready are you to move forward?
Yeah, absolutely. And thank you so much. I think it's a really amazing moment that we're in right now, because on one hand, we have this huge wave where we don't have enough supply to meet the demand for care. And on the other hand, I think the solutions that health systems would pursue in the past, like consolidation or aggregation, raising prices, they're not going to work. And so there's no choice but to find a way to allow or help the system kind of deliver that care and potentially increase productivity, but do it with a smile on their face. And that's a really, really difficult kind of needle to thread. So we're live with some really large academic medical centers, and recently, for example, we announced University of Kansas, where we'll be scaling up to 2,000 clinicians. We do a deep integration with all the large medical record systems as well. And so, for example, in Epic, we can pre-template all those orders, and we want to get into actually templating problem lists, for example. So this needs to feel, to me, like air conditioning. It needs to feel like something where it's in the background as much as possible, and only kind of taking any of my attention, getting any of my eyeballs when it's actually creating real above and beyond value. From an oncology perspective, what I'm so excited about, and I think some of Glenn's research sort of speaks to this as well, the other side of the story is patient and family members. And there's great research from Dartmouth, from Glenn, that suggests that people sometimes forget up to 80% of what they've heard from their health professionals, nurses, doctors. It's just how we're wired as humans. And so if we can find a way to leverage the same technology that can help the clinician sort of fully focus on their patient, but then also help the patient afterwards and their family members be on the same page on what was discussed, the metaphors that the clinician used to describe a certain condition, then I think this starts to become less of a tool, and something really aspirational. And I think something aligned with Glenn, I think what you are getting at is it starts to flip the script a little bit on what care delivery is all about.
Thank
Yeah,
you.
thank you. Thank you for the question. What I think we've seen, I think I'm going to hold the questions there. I'm so sorry. But what I think I'm going to do is to try and ask people to reflect a little bit here. You're dealing with 130 million, and you're bringing in new technologies to help the clinicians and probably prepare the patient, as you mentioned. Shiv, you've given us a glimpse into a co-pilot system that is not a scribe, but an automated scribe that you can trust and then verify, or verify and then hopefully trust that the record is accurate, plus handing that off to the family and the patient themselves. So do you have a sense of confidence here or worry about how this is going to go?
I can go first.
Yeah.
I have a sense of confidence. I think people use the term tipping point a lot, and I think it's overused, but we are really in healthcare with the terms of patients, the amount of caregivers coming out of school and being trained. We talked about that a lot yesterday, employment. So I have high confidence things like a bridge and other tools that we're developing at Optum are going to become commonplace. And the goal is you don't even know they're there. And we're a long ways away from that, don't get me wrong. But I think eventually we're going to it's just going to be part of practice and part of medical school training in this next generation of caregivers that we're training right now.
Okay.
Yeah, I'm very optimistic. I too do a lot of work with artificial intelligence and these large language models, figuring out how we can give recommendations based on it, how we can bring insights. One of my concerns is I don't think our regulatory system knows how to respond to this. So there are, for a policy person, there's an open FDA recommendation around decision support and what you need to do if you're having a recommendation. Additionally, the Office of National Coordinator for Health IT just released a rule that talks about how they're going to govern AI and recommendations. We have to pay attention to these. They're emerging. The first time there's a big miss with this, it's going to be in the news, and the regulators will feel like they have to respond. So I am optimistic, but also cautious. When I talk about tech-enabled healthcare, these are powerful tools. Anytime I have a powerful tool, there is some safety concern, and how am I really conscious about what that safety concern is and be sure that I'm mitigating it with multiple sets of eyes.
Yeah, thank you. Shiv, briefly?
Yeah, I 100% agree with everything that's been shared so far. I remember when I was training during fellowship, there was a cardiothoracic surgeon who would absolutely drill, his fellows. They never slept. And sometimes in the operating room, he would say pressure creates diamonds. And I think what's incredible is that a lot of those fellows did end up being incredible surgeons over time. But I think about this moment right now in healthcare, and I think pressure is forcing us as a system to create diamonds right now in one way or another. And we're finding a way to leverage. I think we're going to continue to find a way to leverage technologies in a very deliberate and mindful and cautious way that still actually creates the value that we need to see right now, because there is a public health emergency in terms of nursing burnout, clinician burnout. The profession just isn't what it was before. So that framework of knowing where to apply this to automate, knowing where to apply this to simply assist is going to be so crucial, because if we are not deliberate about how we approach that, then I think we're going to land into those sort of, sticky, hairy areas where we could see a bad outcome because we thought we could automate, an advanced clinical decision, mistakenly.
Can you join me in thanking these speakers? Thank you very much. Thanks very much, guys. Thank you.